change tack for the next session. And it gives me great pleasure to invite Dimitris Papamichael to talk about adjuvant chemotherapy in rectal cancer. And I probably don't need to ask you to keep the time because you've got a flight to catch. So.
Well, thank you very much, Rob, and thank you, Vangelis, for the invitation and for asking me to talk about such an easy and non-controversial subject at this time of the day. So, adjuvant treatment after curative resection. By the way, this is Heraklion, it's just down the road, and this is where I've spent many summers in my childhood. So, no disclosures in relation to this talk. So, over the last day and a half, we've heard about the major improvements in terms of controlling local failure. However, I think it's fair to say that we have not really achieved as much in terms of controlling distant spread of the disease. And this is where adjuvant therapy comes in. So I will be looking very briefly into some of the pre-TME era data. Then I look at the most important trials in relation to chemoradiation, surgery, and adjuvant chemotherapy. I look at some of the guidelines and what they advise us to do, and then look at take a glimpse into the future, and then hopefully conclude. So when we consider chemotherapy in this context, in the context of this talk, we're talking about chemotherapy for non-metastatic colorectal cancer in patients who've had surgery. And we also consider it in the context of chemoradiation. And I think we can all agree that this bit does not really have any therapeutic impact in relation to systemic disease. So the aim is to eradicate micrometastatic disease and prevent distant recurrence. And the real issue here is when is it indicated? And I think the benchmark may be a bit of a moving target, because some people consider preoperative staging, especially if you have a Gina Brown in your group of radiologists. You might consider post-op histopathology report, or a combination of the two. So let's look at the pre-TME era data, and see these are some of the American intergroup pooled analysis, and as you can see, the best data are with surgery, adjuvant chemotherapy, and infusion, adjuvant radiotherapy with infusion of chemotherapy. It's not very clear on this slide, but you can take it from me. The other data we've had relate to the so-called quick and simple and reliable trial from the UK, and you may be aware of the fact that some of the patients included in this study were rectal cancer patients, and those who did receive chemotherapy appeared to have a lower 5-year recurrence, which was statistically significantly better. And we have some Japanese data. As you know, the Japanese use few prodrugs, such as UFT. And here you have a hazard ratio of 0.82 for the use of adjuvant oral fluoropyrimidines. Now, I hope that you all consider that these data that I've just shown you have a historical value, but they're not really relevant to what we do nowadays. So there was also a Cochrane report published in 2012, included just under 10,000 patients from 21 trials. The difficulty is that these trials run through multiple decades, they have great heterogeneity amongst them, and despite that, the hazard ratio had an overall survival of 0.88 hazard ratio, and also 0.75 for DFS. And and these are the data for the DFS for this Cochrane meta-analysis, 0.75 and 0.83 for overall survival for adding chemotherapy after surgery. What about the more so-called modern trials? So I think the most important trials are the URTC trial, the Italian one, Chronicle, ROB study, the Dutch trial, and one or two meta-analyses. Now, what do all these have in common? The fact that none of them are actually positive. And this is the first publication from the URTC trial, which showed no overall benefit in terms of overall survival for adjuvant or no adjuvant chemotherapy, and no PFS benefit either. However, when they looked at the breakdown of the various stages, it was suggested that those early YP T0s to T2s might get some benefit from adjuvant chemotherapy. However, when we had the update of this study published in 2014 with a 10.4-year follow-up, there was no difference in terms of overall survival and PFS. In fact, this benefit that we saw early on with adjuvant chemotherapy for the T0 to T2s disappeared. Interestingly, the chemotherapy arms did show a lower local recurrence. One of the difficulties in explaining this data is that the chemotherapy that was given would perhaps be considered inadequate by a number of medical oncologists. The Italian trial, published around about the same time, included 655 patients with clinical T3, T4 cancers, chemoradiation, and then randomized after surgery to 6 cycles of 5-FU versus observation. Again, the 5-FU leucovorin was lower dose than might be considered adequate, but the results was that there was no difference in terms of overall survival, local control, or distant spread. Chronicle trial, very nice trial. However, I think the investigators in the UK were not convinced, unfortunately, and therefore this trial closed after poor accrual. Interestingly, the observation group did have a high number of node-positive patients, but there was no suggestion that there was any benefit for the chemotherapy arm. The Dutch trial, pre-op radiotherapy or chemoradiotherapy followed by TME, and then patients randomized to receive chemotherapy or observation. More than 80% had stage 3 disease on the basis of the pathology report, but there was no difference in terms of overall survival or disease-free survival. And this is the meta-analysis from Brugum, which shows that indeed there was no impact in terms of adjuvant receiving adjuvant therapy in this group of patients. What about adding oxaliplatin? Well, there were a number of trials, Accord, STAR, German, and PDAC6. I will just concentrate on the German, and I'll say a few words about the ADOR trial later. So the German trial looked at chemoradiation, standard chemoradiation, but with infusion of 5-FU, and then adjuvant 5-FU for 4 months. The experimental arm unfortunately asked 2 questions, adding oxaliplatin to the radiotherapy bit, but also adding FOLFOX adjuvantly. So when you ask 2 questions, it's a bit difficult to know what's what. What it showed was a disease-free survival advantage with a hazard ratio of 0.79 and a 3-year DFS of 71 versus 76 just, and again about a 4% improvement at 5 years. However, there was no improvement in terms of overall survival in this study. What about the ADORE trial? This trial looked at patients who completed preoperative long-course chemoradiation and then had surgery, who had YP3, T3, 4, N0 or any N status. So the patients received bolus, Mayo Clinic schedule, or FOLFOX, and this showed an improvement in terms of disease-free survival with a hazard ratio of 0.657. It did show a small improvement in terms of overall survival as well. So this was a trial which looked at adjuvant 5-fluorocovorin versus FOLFOX for 4 months, interesting duration at that time. The primary endpoint was DFS, so from that point of view it was a positive trial, but when the benefit was evaluated post-chemoradiation, only patients with stage 3 disease had a DFS benefit. There was no observational arm, and this was a randomized phase 2 study with an 80% power. So what have these oxaliplatin trials shown us? They've shown us that, well, I think all these trials used low-dose oxaliplatin as a radiosensitizer, and I think there is still a lot of controversy about whether this helps or not. And 2 trials mandated oxaliplatin as a postoperative adjuvant, so you don't really know which small DFS benefit. And some of these trials did not mandate TME, so difficult to understand what went on there. So why do we have these negative results? Somebody put up a slide this morning, one of the speakers, from Lars Palman's paper on this issue of stage migration. And I think this is very true. I think that this does exist. We do have better surgery these days. And I think that part of the reason why adjuvant chemotherapy is not working is that we have improved. We've got better at what we do, especially the surgeons. The other thing to consider, I think, is that this difference between stage 2 and stage 3 may be too broad, and if you're trying to look for a 10% difference, may not be enough. Some patients, I think, in this studies had stage 2 disease, and if we dare extrapolate the stage 2 data in colon cancer, well, we know that in that setting, adjuvant chemotherapy doesn't add much anyway. Now, the other, I think, important reason is that if you consider chemoradiation for some of these patients, well, that takes about 6 weeks. Then you wait, as was discussed earlier this afternoon, for 6 to 8 weeks after surgery, after chemoradiation, and then you wait for the patient to recover from surgery. And I think this is 4 to 6 weeks is actually quite early to see patients being ready to receive adjuvant chemotherapy. So if you wait for 16 to 20 weeks after your diagnosis to actually consider giving adjuvant chemotherapy, that may be a bit late. And I think most of the medical oncologists in the audience who treat colon cancer, if you had somebody with stage 3 disease who waits for 20 weeks or longer, you would be very, very uncomfortable. And just to remind you that the longer you wait beyond surgery for giving adjuvant chemotherapy, the less likely you are to have an impact on micrometastatic disease. So what should we do? Well, if you have short-course radiotherapy and you have immediate surgery, we normally treat in our department as per colon cancer, according to histology, although that's hardly evidence-based, because that's rectal cancer, it's not colon cancer. After chemoradiation, I think if you've achieved a path CR, I wonder if there is any benefit to giving adjuvant chemotherapy. If you've had a partial response, then chemotherapy is indicated, but what we've seen so far does not make us very comfortable or very enthusiastic. And if you have no response, well, that's really bad news, and that's when you really need something good, but I don't know what this is. So, what are the guidelines? Well, these are the NCCN guidelines. This is for T3NEN disease, and I don't really know what to make of this, to be honest. They've decided that FOLFOX or CAPOX up front could be part of standard of care, then chemoradiation, and then restaging, and then surgery. I think a lot of these patients may be overtreated. They propose exactly the same thing for patients who have T3 but with involved CRM. That, I think, is much more acceptable. And these are Rob's and his group's ESMO Clinical Practice Guidelines, which were recently published, a very nice paper. But what do they tell us about giving adjuvant chemotherapy? Well, this is very nicely written, very carefully written. But I think when it comes to the crunch during the MDT meeting, I don't think it helps us very much. There are some future trials which may or may not help us to answer some of these questions. This is not a future trial, this is the Polish trial, and whatever you may say many things about it. For example, it doesn't have a standard arm, but I think this arm, the short course radiotherapy followed by FOLFOX, did achieve some rather good results. I think it's fair to say that. So this may be pointing towards the right direction. Many of you mentioned the Rapido trial this morning and this afternoon, and this is meant to be for locally advanced tumors. This may give us some answers as to whether the total neoadjuvant approach is good for this bad or ugly tumors. The caveat, of course, is that you need to have good MRI staging to choose these patients. This prospect trial in different patients, a different group of patients earlier, so there may be some over-treatment going there, but I think it's also asking a relevant question as well. And this proposed CREATE trial, which is MDT-driven and looks at the MDT decision to have surgery, chemoradiation, or short course, and then 12 weeks of post-op CAPOX, FOLFOX, or indeed 12 weeks of neoadjuvant FOLFOX, CAPOX, and then follow the MDT decision. So I think all these trials will give us some answers. So to conclude, I think adjuvant chemotherapy should not be standard of care for all fully resected localized rectal cancer patients. It should be considered for patients at risk who did not receive neoadjuvant therapy for whatever reason, so in those patients you should go on the YP stage. It should be considered for stage 3 patients for neoadjuvant chemotherapy. And I think it should be a joint decision between patient and clinician, balancing the risks and benefits. And it brings me to the last bit, that when it comes to the elderly patients, a special interest of mine, there I think we have very little or no data to go on and to advise this group of patients. Thank you for your attention.
So, Dimitri, I've got one question for you to start. It was a very nice talk. So, you say that we can't take colon cancer trials into account.
Well, we do.
Okay, but the question I have for you is, you seem like me to, against your better judgment, you end up giving chemotherapy for patients who are at risk, high risk. Okay, so my question is, what is the duration of chemotherapy that you're going to give?
Okay, I have been influenced by the IDEA data and by what John Souvlagos has been preaching over the last year or so. So, in fact, we give 3 months of treatment, because I think that's where you'll get most of the benefit.
Okay, that's great.
Again, that's another huge extrapolation from the colon cancer data. That's what I do.
Yes, two short questions, Dimitri. First, what do you do if you have R1 circumferential resection after TME and neoadjuvant radiochemotherapy? Because we know that there is a high risk of distant metastasis, so we always give FOLFOX for 6 months. And what is your choice? And second question, if you have a patient with temporary stoma, and we need to give adjuvant chemotherapy if it's not positive, even if it's R0, we give FOLFOX. Do you give during with the stoma, or you close the stoma and you give after the chemotherapy? Because there is two possibilities.
Yeah. So the first question was
R1
R1. Yeah. Well, when we have R1, we despair, of course, but we do give adjuvant chemotherapy. I don't know whether 3 or 6 months is any better. I think in many patients you've lost the game.
With the stoma,
with the stoma, if it's a colostomy and not an ileostomy, we dare give Capox, and that's usually no problem. But I think it's fair to say that for ileostomy patients, you may end up finding the pills in the colostomy bags. So we tend to go for FOLFOX in these patients.
The aim of adjuvant chemotherapy is to prevent distant metastases. We know that patients having a RO resection in the end may have problems, postoperative problems, increased morbidity, anastomotic leak, which actually makes adjuvant chemotherapy not possible.
Yes.
And these may miss actually the benefit if they need chemotherapy. So should there be any place for neoadjuvant chemotherapy, not just to downsize or downstage the primary disease, but to prevent the metastatic disease?
Very much so. I think that your chances of getting in your adjuvant chemotherapy are much better if you give it before your surgery rather than after. There's no doubt about that. So that's why I look forward to the results of some of these studies.
Yeah, exactly.
Afterwards it's very tricky. Some patients end up not getting anything because they have not really recovered soon enough after surgery.
Of course, not all patients need chemotherapy, either before or after.
One final question.
In a patient with
negative notes on pathology, but positive EMBI, would you suggest adjuvant chemotherapy?
We do. We do because we believe it's a very high-risk feature, yes.
Okay. Well, thank you very much for that.